terrific to be here, quite honestly. I'm excited about this opportunity and the work that we've been doing. As Stephanie mentioned, I work at the Iowa Department of Public Health. I'm in the Division of Behavioral Health, and within that, I work in the Office of Disability, Injury, and Violence Prevention. And I am, as Stephanie said, the Brain Injury Grant Manager. It's a grant that we have from the Administration for Community Living, a TBI, Traumatic Brain Injury State Program grant. Iowa is one of 27 states that receives funding from ACL, as we call them, to provide services and supports. It funds on a 3-year grant cycle. And in this grant cycle, we've begun to focus on what we call underserved or inappropriately served communities. And so those are individuals who possibly unknown to themselves or providers that are working with them, that they have an undiagnosed brain injury. And we, as June will share with us a little bit later on in the presentation, it certainly has an impact on outcomes for individuals whose brain injury is, significant enough that it impacts their daily life. So with that, I'll just let June introduce herself.
Thank you, Jim, and thank you, Stephanie, for having us today. With Jim, I'm quite excited to be able to be offered this opportunity to share with your group. June Klein-Bacon, I am from Northeast Iowa, have been in the brain injury field or human services field for about 17, 18 years now. Most of that serving people with brain injury in a few different capacities. I've been with the Brain Injury Alliance of Iowa for 7 years, serve as a neuro resource facilitator, and we'll share a little bit about that service later in the presentation, but also have provided project management for the last 6 years, mostly working on the contracts with the Department of Public Health related to that Administration for Community Living grant, and doing outreach and education with underserved or inappropriately served groups.
All right. Next slide, June.
There we go.
All right. So just briefly share some disclosures with you that are important, not typically very exciting, but as previously mentioned, the development of this presentation is supported by the Brain Injury Service Program of the Iowa Department of Public Health through a contract with the Brain Injury Alliance of Iowa. This project was supported in part by, I won't read the grant number, but it's from the U.S. Administration for Community Living, Department of Health and Human Services in Washington, D.C. The screening tools that we'll review a little bit later on in the presentation. The adult screening tool is a modified tool from the OSU TBI ID ABI, which is a screening tool developed by Dr. John Corrigan out of the Ohio State University. And one disclosure I don't have on there, but I will say, because it was just recently approved by our Advisory Council on Brain Injuries, so we were able to include it in the slide deck, but forgot to put it in the disclosures, is we have a pediatric screening tool, excuse me, that was adapted from the Brain Injury Check Survey tool from Colorado State University. Lastly, and probably most importantly, the content of this presentation is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard in this presentation. Okay, next slide. So 3 primary objectives today. We're just going to kind of give you a crash course in BI 101. I've had many BI 101s that can go for about a half a day. So you're going to get just a real quick crash course in that with more opportunities later if you have interest. Talk a little bit about some considerations of brain injury in the refugee communities. And then, as I mentioned, we'll talk a little bit about brain injury screening and assessment that is available to you. So let's talk a little bit about what a brain injury is. So um, in this definition that you have here, you can, of course, everybody Googles everything. You can find various different definitions of what a brain injury is. But the source of this is the Essential Brain Injury Guide from the Brain Injury Association of America in its 5th edition. And that really is kind of the gold standard for training and understanding about brain injury. But an acquired brain injury is an injury to the brain that is not hereditary, congenital, degenerative, or induced by birth trauma. The injury results in change in neuronal activity, which affects the physical integrity, the metabolic activity, or the functional ability of nerve cells in the brain. An acquired brain injury is an injury to the brain that occurs after birth, where it is presumed there was normal brain development and the injury to the brain was subsequently acquired. Now, you often hear the term traumatic brain injury. That's really all brain injuries are an acquired brain injury, but within that there is what we refer to as traumatic brain injuries, and those are an alteration in brain function or other evidence of brain pathology caused by an external force. We often use the term bump, blow, or jolt to the head. And there are two primary mechanisms of TBI, and those are ones that are involving impact to the head and those involving inertial forces which affect the brain. Um, Traumatic injuries result from contact with either the head, when the head is struck by or against an object. They can be open wounds or penetrating injury, and closed or non-penetrating injury. Non-traumatic brain injuries are types of brain injuries that may be caused by stroke, infection, anoxia, which is lack of oxygen, vascular lesions or tumor of the brain. We won't go over this today, but in Iowa Administrative Code, there are 46 definitions that meet the criteria for brain injury. But we'll share a little bit what the Code of Iowa considers a brain injury. Is clinically evident damage to the brain resulting directly or indirectly from trauma, infection, anoxia, vascular lesions, or tumor of the brain, not primarily related to a degenerative disease or aging process which temporarily or permanently impairs a person's physical, cognitive, or behavioral functions and is diagnosed by a physician. The diagnosis of clinically evident damage to the brain used for diagnosis of brain injury shall be the same as specified by rule for eligibility for the home and community-based waiver services for persons who are on the brain injury waiver under the medical assistance program of the Department of Human Services. Next slide. Okay. So let's talk a little bit about the anatomy of the brain, trauma, and concussion and coma. And June's going to share with you about those slides.
So the website that's cited here, has lots of really great information that describes various injuries to the brain. So beginning with injuries to the skull, which can range from linear fractures or simple cracks to the skull. Most of the time, people are not going to require treatment with linear fractures, as is typically the force is not large enough to break the skull and produce damage to the brain. When we have depressed skull fractures, these occur when the bone presses on the brain, and compound fractures break the skin and the bone, which of course is going to increase the possibility of infection from the environment. When we think about injuries involving vessels to the brain, this can lead to, pooling of the blood in abnormal places, which we typically are going to hear referred to as hematomas. There are different types of hematomas. So depending on when we think about the layers of the brain and in connection to the skull and then also the brain itself, hematomas can occur between those different layers. We know that There can be pooling of blood that can happen surrounding the brain, but also internally with the brain, with blood vessels leading to brain tissue damage. When we think about that brain tissue, the brain tissue itself, we really we can put things on a continuum and think about mild, moderate, and severe injuries. Concussion, which we often hear referred to as a mild traumatic brain injury, is typically going to be temporary and reversible. This happens with loss of brain function as a result of metabolic changes in the brain, which Jim referenced earlier. With concussion, structural damage is not going to be picked up on scans. And so we often hear about concussion with our youth, particularly in involving sports or those types of activities. However, concussions can occur as a result of falls, being hit on top of the head or hit on the head, blows to the neck and chest area as well. Contusions happen with the brain when there's actually bruising happening with brain tissue, particularly when the brain rocks back and forth inside of our skull. For those that may or may not be aware, our brain, sitting on top of our brainstem, actually floats in cerebral fluid. And so, if we have a force that occurs and that brain rocks within the skull, we can have damage from that impact when the brain strikes the inside of the skull. So again, some examples of when that can happen: falls, assaults, motor vehicle crashes are some examples. We also know that the brain can be damaged with lacerations. So we actually have tearing and cuts into the brain tissue. And lastly, when we have forces that are strong enough, we have something that's called diffuse axonal injuries. And this refers to damage to the axons, the neurons within our brain. And those can be damaged by the sheer force that is going through the brain. This can happen again with any number of activities. That when there is a high velocity stop, such as a motor vehicle crash, an assault, but also can occur with falls. And again, as Jim mentioned, there are 46. I think it was 46 different types of brain injuries that are included in Iowa code. This slide, I think, is really interesting. And for anybody that might have interest, the Brain Injury Alliance of Iowa has a one-page handout that actually reflects this information in a very similar fashion. When we talk about the different types so the previous slide we talked about, different types of injury, but this slide really takes a deeper dive into some great information on the functions of our brain. So just as a reminder, our brain is what is our control center. Controls our body, personality, tone of voice, our thought processes, and so our brain is really something that is controlling everything that is and about us. And so this slide is a great representation of what different lobes actually manage and control. And so if we take a look here, just in the orange section, that's referencing the frontal lobe. So things that we often hear about in terms of executive functioning. So things like problem solving, planning, initiation, judgment, organization. Those types of functions in terms of brain activity live in our frontal lobe primarily. When we look at the parietal lobe, which is kind of this pink, and when we think about kind of the top back of our head, this is where a lot of our sensory stuff comes into play. So sense of touch, awareness of relationships, academic skills, that kind of thing is going to come in the parietal lobe. When we look at the occipital lobe, which is the back of the brain, uh, that really is the control center for our vision, perception, as far as being able to read and comprehend information, being able to evaluate information, whether it be spatial recognition, also recognition of printed words, being able to read that type of function. Temporal lobe, we're looking at this green center here, and we have temporal lobes on the right and the left. If you think about your temples, that's where the temporal lobe kind of lives. And this part of our brain really manages our memory, receptive language, also plays a large role in our organization and being able to sequence information and tasks. And then lastly, we've got this area towards the bottom of the brain where we've got our cerebellum, which is going to those functions include things like balance and coordination. And then our brain stem, of course, is basic life functions. So those automatic functions such as breathing, heart rate, sleep wake cycles, and this type of thing. So, one of the reasons we've worked to engage with this group in particular, and thinking about professionals that are serving refugee communities and others, is that we're learning more information about the commonality of refugees experiencing traumatic brain injury. As noted on this slide, you're going to see some, I think, some interesting statistics on this slide, and of course, those are sourced for you if you want more information. But we're seeing studies that speak to the significant incidence and prevalence rates for those who experience torture and traumatic brain injury. The research noted on here also is showing the overall prevalence rates of head injury in refugees was 51%. Um, and I'd like to call attention to some of the statistics that are listed with this research. At least 38% of those with head injury had moderate to severe head injuries that would cause persistent disability. And when we look, and I would note in terms of comparison, when we think about the continuum of mild, moderate to severe, um, really when we're thinking about moderate to severe brain injury, really only about 20% of overall injuries are landing in that moderate to severe range, where 80% are more in that mild. When we look at the second bullet, we're thinking here, for example, about domestic violence alone. The other pieces there around human trafficking and torturing are not statistics that I had access to in preparing for this. But just thinking about domestic violence alone, 30% of domestic violence survivors report a loss of consciousness at least one time, and 67% report residual functional changes as a result of those head related injuries. So I would call attention again, mild traumatic brain injury. When we think about mild traumatic brain injury, typically again only 15 to 20% of those land in the moderate to severe range. And 68% of those are reporting injury that are also reporting effects on their function. And so I'm just going to go back one slide here and think about those functions. So 68% of those that are reporting injuries are reporting challenges that are functional. And when we look at this slide, we really are pulling out a lot of those functional activities of daily life, and being able to participate in daily life that are being affected. So that 68% number could really be any of these functions listed here. All right. So lastly, I would just again share here that 64% of those working with a mental health clinician, their brain injury was not known prior to screening for brain injury. I would share that we're doing a couple of projects here in Iowa to complete brain injury screening. And Jim can correct me if I'm wrong, but I believe that the positivity rates that we're seeing come back are about 50%. So I see Jim shaking his head. So thank you for that confirmation. So we definitely are seeing, and I would note that, frequently in the work that we've done, I can't speak specifically for the screening exercises that are happening, but frequently in exercises that I've been a part of, um, the person does not identify that they have had a brain injury prior to the screening. And so when we see a 50% prevalence rate, that can be pretty significant. So again, when we think about why understanding brain injury or impact of brain injury and why this matters, as we think about the really intense and complicated history that people have and the impact of history on their current function and development, it really becomes important for us to think about the prevalence rates of brain injury among refugee populations and how that affects function. Brain injury can present in so many different ways and so many different arenas. We see high correlation rates between people that experience brain injury and homelessness, incarceration, and even substance use disorders, to name a few examples. When brain injury and those functional changes or challenges are not identified, then we see deficits in working memory or short-term memory loss, challenges with organization, or a variety of losses in function. And so when we start to pick apart some of those functional challenges that a person can be experiencing, we can start to see how traditional treatment might not be as successful or as successful as it could be when brain injury is not identified. And we know that SAMHSA has identified that screening for brain injury is best practice when responding to planning clinical and community-based responses for clients that are being served in health, community, or even in criminal justice services. And so we would like to make the leap uh, that screening for brain injury among refugee communities is also an important practice. So I will go ahead and turn it back over to Jim.
Okay. Well, I need to get my cheaters on. I think that's pretty small print there. So I don't know if you have a way to make that any larger. Um, I can, yeah, mostly for those watching rather than for myself. So a little history on this. Uh, the governor appoints many different commissions and advisory boards. And so the Advisory Council on Brain Injuries is a group of individuals who are subject matter experts on brain injury, representatives of state agencies, but probably most importantly, a family and/or individuals who have lived experience of brain injury. And so I joined IDPH in February of 2019, and they were right in the middle of developing a screening tool that was specific to Iowa. One of the things I think that's important to know is many states are an acquired brain injury state, recognize acquired brain injury in their definition, but many don't. And so the screening tool instruments that were out there probably weren't capturing the acquired brain injuries well enough to be able to adequately screen for lifetime history of brain injury. So the council set out through a series of meetings and with consultation of Dr. Corrigan at The Ohio State University to develop its own unique tool. Now, what I can tell you about this tool is it is available on brain injury website. We should have had, but don't have on there a link to our brain injury website. But if you want to write this down, um, if you just Google idph.iowa, let's see, yeah, .iowa. I've got to go to it myself. My handwriting's so bad, I wrote it down and Now I can't read my handwriting. Yeah, iowa.gov/brain and then hyphen injuries. So, and if you didn't catch that, you can certainly reach out to junior high afterwards. That screening tool is on our website. It's available. It's free and open to the public and available for you to print off. I will tell you also, there is an accompanying um, instruction page on how to complete the screening tool. So there's instructions that will help you with that. Thank you, June. And as you'll know, we have for the adult tool, we have translated that into Arabic, Karen, Karenni, Swahili, and Tigrinya. We have, I have resources if, for those of you who are on the call would have interest to say, please translate this into a different language, please reach out to me in specific, and I can work with internally within our organization, get this screening tool printed out in your language. Certainly well aware that, and I will also say that of the screenings that we did, we had those tested with people for whom that's their first language. So, for example, the Korean tool, we had that reviewed by someone who is Korean to kind of, you know, ascertain to us that it was the translation was accurate. So, but we would be glad to translate that into as many languages as necessary. But let's just kind of briefly walk through it here. It asks four simple questions. I'm getting some um, background noise a little bit, but it asks four simple questions. The first question really gets at finding out if someone has ever had a loss of consciousness, and understanding whether or not, how long they were knocked unconscious. So, for example, in Iowa, the number one cause for a brain injury are falls. So let's say, for example, um, uh, the first question asks if you've ever, had an injury in your lifetime that you were knocked out. And you check yes on that first box in A. And then letter B is going to ask you, how long were you knocked out? And then you can check that box, and that gives some idea of someone who will ultimately kind of take a look at that and help assess with you, how severe uh, injury was. And then C, last question on that first question, that kind of wants to know, how old were you? Because we know certainly the earlier in life you experience a brain injury, the more likelihood that you'll have ongoing concerns. The second question on this screening tool, and I will say this is normed for anyone who is 13 years and older. So that's who this is focused on. We do have a pediatric one, which is the next slide. We'll get into that one in a minute. But the second question really wants to ask you about any repeated impacts you've had to the head. Most often we would think of people who are involved in sporting activities, football, repeated concussions. Some, might experience that sadly through intimate partner violence. So that question is getting at, have you had repeated blows to the head, and how old you were when that happened. The third question wants to know if you've ever lost consciousness from a drug overdose or being. This question really speaks to the opioid epidemic, that we see across the nation, which is significantly high issue across the country, but in Ohio, I think that question was influenced by the opioid epidemic in Ohio. And then that's certainly too, asking questions about if you've had a drug overdose or if you've ever been choked. And so that question there would certainly address concerns related to intimate partner violence. So those are the first three questions. Now, what makes, I think, Iowa's tool unique over some of the other tools, over Dr. Corrigan's uh, OSU TBIID, and the TBIID stands for Traumatic Brain Injury Identification Method. Theirs is much longer, but our tool in specific added this fourth question to look at what we called the acquired brain injury. Stephanie had, or excuse me, June had briefly referenced the 46, as did I, the 46 different diagnoses in Iowa Administrative Code. But for those of you who have interest to know what those are, of course, if you reach out, I could just send you that list. I have that copied. I could, send out to you. But it's found in the Department of Human Services Administrative Code. In their department number is 441, so you would find it in 441 in Chapter 83. 81, which is the brain injury waiver part of the Iowa Administrative Code for the brain injury waiver. And so for this, I think it number four, there's a lot where people probably don't think of those types of things as a brain injury, epilepsy, or seizures. But I want to point out a couple in particular as it relates back to the torture, which again, that may involve, some traumatic issues. But in Iowa Administrative Code, that second to last box down there says child or adult maltreatment syndrome. So you may have individuals that you work with who have experienced child or adult maltreatment. That is considered a brain injury according to Iowa Administrative Code. And depending on the severity of that, in terms of how it's impacted their activities of daily living, it certainly is something that to be aware of in terms of accessing services and support. So that's the adult tool. I am working to hopefully get this online electronically on the department's Your Life Iowa website. That's been kind of a slow process, but we're working on it. But if any of you that are on the call participate and utilize the county's CSN system, which is used by the county system, that is available to you electronically through that system if you use theirs. So that's the adult one. Our time's limited, so we'll just move on to the pediatric one. And I can certainly, after this call, if you have other questions about how to get access to this, how do I use it, can we, June and or I would be glad to come out and do some training on that. But let's move on to the pediatric one. This is, again, adapted from a screening tool from Colorado State University. Again, we added Iowa's own flavor to this. And it's for use for individuals age 5 to 21. And has 3 questions. And the first question, again, is really looking at, has your doctor ever diagnosed you with a brain injury? If they haven't, you move to question 3. But if you have, then ask some questions. What was the mechanism of that injury? Did you lose consciousness, and for how long, and how it impacted you? And June's going to talk a little bit about, there's this, people say, okay, you screen positive, now what? Well, in just a minute, June will talk about the now what to kind of close that loop for you. The second question, again, gets at these acquired brain injuries. So if you're working with someone or have lived experience of any of these types of things, those potentially can be considered a brain injury. And then that last question just kind of gets at if you've ever been to the emergency room related to some type of a brain injury. Now, I do want to say, just to give the disclaimer, completing the screening tool to determine if a person may have had a brain injury, it's important to note the screening does not result in a diagnosis. It's not intended to be used for determination and does not replace a face-to-face evaluation and assessment with a trained professional. So obviously, if this is a tool that you would utilize, then certainly you want to follow up with a medical professional. Um, I will tell you that lastly, before I turn it back over to June, um, when we started this process, we knew there would be challenges and barriers um, given the uh, cultural differences, language barriers. So we have established a community of practice of a number of individuals who are we are working with to really, frankly, educate us on ways that we can make this tool more effective so it's useful to you, um, and address gaps and needs that exist. And so if that's something you have interest in participating in, again, reach out to June or I. That group meets next on December 10th at 1 o'clock. And we really, I think, have a great group of people, but would always love to have more who want to kind of move this needle to bring this to awareness. All of this information that we learn goes back, obviously not individual specific, but it's aggregated, and it goes back to our federal partner to raise awareness, um, uh, to the fact that this, you know, population of individuals has brain injuries, and hopefully it helps us again move that needle for additional services and supports. So, June, turn it back over to you.
Thank you, Jim. So the next few slides, we're going to just again kind of talk about function and how you might take a look at function as a result of possible brain injury or diagnosed brain injury. Back on slide 7, we had that pictorial description with the different lobes of the brain and the functions connected to those. And this slide just gives us a very similar list to think about those functions. And it's actually the backside of the handout that I mentioned that we would be glad to share with anyone. This gives us a look at those functions in the framework of thinking about the physical, behavioral or emotional or cognitive challenges or deficits that somebody might experience as a result of brain injury. And when we look and think about these functions, then we can also think about what kinds of accommodations or what kinds of strategies might be used to mitigate and manage loss of function. And so I'm just I've got a couple of slides here that I'm just gonna use as some examples. Of course, if you are in a position that you might have staff providing some support, or you're providing support to a number of individuals that you might come in contact with that might have brain injury, uh, we are happy to put together or redo, this session, for example, for you and your team, just gaining some understanding on the fundamentals of brain injury and kind of expanding on that can be really helpful for staff that might be in a place that screening for brain injury might be considered. So some additional kind of interventions that can be considered when kind of looking at those functions and that loss of function. Really, I think it's really important to think about what is the loss of function, what is the challenge, and how can that person work to build strategies to manage that deficit. And so we have a few examples here, but certainly not all encompassing for everyone. So maintaining some common ones, maintaining a predictable routine is incredibly important. Working to establish environmental cues, supporting prioritized checklists and reminders. I think before we started the call, we were talking about Post-its. Post-its might come in handy. We know particularly for younger generations, use of technology can be something that they can incorporate into their day. easily than others. So that may enhance a person's function. When completing tasks, thinking about focusing on one task at a time and kind of getting away from that idea of multitasking, so that we can complete tasks in its entirety and then move forward. Individuals being able to benefit from taking regular breaks. Fatigue is something that is very common among individuals that experience brain injury, especially early on in the recovery process. We see that particularly with concussion, that those metabolic changes, but the brain is working very hard to kind of uh, reconnect, build new connections in response to brain injury, in addition to those metabolic changes that can happen as a result of brain injury. And so incorporating breaks, this morning I did a session. We were talking about substance use disorder, a typical 2 to 3 hour group, maybe, much too intense for somebody that experiences brain injury. And so they may be able to tolerate 45 minutes, where somebody else might be able to do a 2 or 3 hour group. Planning ahead for situations that might bring about poor judgment, being able to talk about potential obstacles. We frequently are talking with our clients and family members and professionals that work with people with brain injury that experience challenges with poor judgment, is this idea of pre-teaching prior to an event that might be triggering or bring about poor judgment, an agreed upon response during an activity where there might be, poor judgment exhibited, and then that post response, and talking with that person about what happened, and what could have been different if it wasn't good, but also celebrating, if there were strides made in making a sound judgment. So here, just a few more. So again, provision of environmental cues. That could be signage, that could be calendars, audible alarms. That kind of thing can absolutely be helpful to support somebody get through their routines. Linking behaviors to things that naturally go together. So if we know that, somebody always eats breakfast, or always takes a shower in the morning, maybe linking taking their medications at the same time, so that they can have that linkage, and that targeted behavior occur. Um, for individuals that lack or have challenges around the area of initiation, or we might sometimes hear people refer to, oh, that person doesn't have any motivation to get anything done. That could be due to depression. We know that many people experience depression connected to brain injury. There's actually a pretty high prevalence rates there. But we also know that just the area of that area of the brain may also be impacted. And so kind of looping back again to these ideas of linking behaviors together or environmental cues might be very helpful for initiation and motivation as well. This last bullet here just talks about the idea of counseling, and being able to take a look at what are realistic expectations for that person, but also for the family or caregivers to also be connected to going through that process, and recognizing, what are the grief points that we might be feeling as due to maybe loss of income or changes in relationships. Those can be very real, and figuring out how to cope and problem solve through those situations can be really stressful. So there may be opportunities to think about different types of counseling may benefit some more than others. So I'm going to just note here too. So we're going to get into our just our last couple of slides here. Our Neuro Resource Facilitation Program, I want to share a little bit about the Brain Injury Alliance of Iowa. We are part of the Brain Injury Services Program here in Iowa. The Brain Injury Alliance of Iowa is available to all Iowans. We serve anybody living in the state. Our primary service line is this neuro resource facilitation. And what that service line is really designed to do is to work with, people to access information that they might need around what is brain injury, how might we access services in the community, in thinking about informed choices. It's a phone-based program. All of our staff also have access to webcams, so we can do kind of webcam work as well, if people need a face-to-face. Knowing that our knowledge is growing in terms of working with the refugee community, we also are working to engage with the professionals that are working with the refugee community, recognizing that our efforts may involve case consultation. So as professionals, if you have questions about brain injury, if you have a client that maybe you start screening, or somebody that you know has brain injury that you're working with, you are welcome to give our office a call as well. And we are happy to provide what we call case consultation or technical assistance with those individual situations, just to try to ask questions and identify how we might be able to give you information so that you can um, serve in a different way when it comes to providing supports to somebody with brain injury. As far as additional resources and information on our website, we have online training and videos. We have social media platforms as well, and also our organization supports the platform of support groups currently online because of the pandemic, of course. But again, we are in a position that we're working to learn a lot, and increase our ability to serve the refugee community, among others here in Iowa. So with that, I think I will turn it back over to Jim to see if he has any parting words. Otherwise, we just want to very much thank you for this opportunity. And if there are questions that have arisen, we would welcome those as well.
Thank you, June. Stephanie, thank you so much. I think looking over here at the clock with the time we have left, I'm not known to be a man of a lot of words, but I could probably fill up the next 8 minutes, but I won't. So if there are questions, we'll just go ahead and entertain those with the time we have remaining.
And if anybody is unable to get their audio to work, if you have questions, you're welcome to type into the chat as well. And I don't see anything coming in as of yet, but as people are getting the unmute button and chats to work, if they are typing in questions, the video again will be available on the Rossi website, available to view, for free. It'll just kind of live on that same web page that you went to register for the foreseeable future. And so both Jim and June have posted their contact information here. If you're ever in need of their contact information and can't access that video for any reason, or you're always welcome to reach out to either myself. Valerie Bouvat de Virginie is also on this video, and many of you have her contact information as well. She's the Rossi AmeriCorps Vista. So you're welcome to reach out to us, and we're always happy to connect you in the future as well. And then just a comment came in from Tina. Thank you so much. Great training, lots of great information. Yeah, thank you both, Jim and June, both. Thank you both very much for your time today. I feel like I should have just paid a lot of money for the amount and the quality of information that you were able to just provide us. Thank you very much for what you're doing in our community too. I mean, I know like we have mental health providers that have just, there's been a lot of benefit from your partnership and the work that you guys do. So we're very grateful.
Yeah. Well, Stephanie, if you're so inclined, I'll give you my Venmo account and we can take care of that. Let me just leave you with one thought. I there's a neuropsychologist that I think so highly of. Uh, his name is Dr. Ross Green with an E. He's a pediatric neuropsychologist. I believe he's now out of Virginia Tech University, and he's authored many books. Has an institute for, I believe it's called the Institute for Collaborative Problem Solving. But he specifically, his focus is in the area of working with children that he describes as easily frustrated and chronically inflexible. That might describe most toddlers, but that being said, there's one phrase that he uses that just really speaks to me, and I think it's so important to think about it when you're struggling with people you're working with who just you're hitting a brick wall or you can't figure it out. Always remember what he says. He says, your explanation guides your intervention. So we know oftentimes that explanation is an undiagnosed brain injury. And once that is known, it's kind of like a light bulb moment, and it can really change the trajectory of yeah, Tina, I did too. It's a phenomenal book. I would highly recommend it. Tina says she's used that book. But anyway, you know, if there is a brain injury and you realize it really changes the trajectory of how you intervene and what you do, and can really improve outcomes. So we'll just leave it with that. And you're on mute, Stephanie.
I got it.
Yeah.
Hey, and if anyone was wondering, just in case they weren't able to see the chat, the title of that book was Explosive Child. All right, well, if there are no other questions, we'll go ahead and end today's webinar. I just wanted to say thank you again to our experts. Thank you to everyone for being here today, for your interest in wanting to serve our refugee communities better. If you ever have follow-up questions or ways that we can connect in the future, Valerie and I are always available to help anybody that has questions or are wanting to connect. Thank you all very much, and we'll have this video up again by the end of the week.
All right. Thanks.